Welcome back to the deep dive. When we usually talk about cancer drugs, the language is, well, it's pretty violent.
It is. We talk about scorched earth, chemical warfare.
Exactly. Bombing the tumor. And it's always this story of collateral damage, where you accept that you're going to really hurt the patient just to have a shot at killing the disease.
That's the classic narrative of cytotoxic chemotherapy, for sure. It's the sledgehammer approach.
Right. But today, looking at the sources you've pulled, we're diving into chapters 40 and 54 from Katzling and Trevor's, and the big one, chapter 68 from Goodman and Gilman's. It feels like we're in a completely different genre of warfare. This isn't a carpet bombing. This feels more like counterintelligence.
That is the perfect way to frame it. I mean, we're not trying to physically poison the cell, at least not at first.
Or cutting its communication lines.
We're engaging in espionage. We're starving the signal, not the cell itself.
So this is Pharma 68, and that's our working title. Scarring the signal, not the cell. And the whole idea seems to be that some of these major cancers, breast, prostate, endometrial, they're not just chaotic rebels growing wildly.
No, they're not. They're actually still following orders.
So that's the vulnerability.
That is the fundamental insight. A traditional chemotherapy drug, it targets any cell that's dividing rapidly. It doesn't care why it's dividing, just that it is.
It's indiscriminate.
Totally. But hormonal therapy recognizes that these cancerous tissues, they retain a memory of their origin. They still have the original software of the breast or the prostate they came from.
And that software has a rule.
A very specific rule. I only grow when the boss tells me to.
The hormone.
Precisely. They are hormone dependent. They need a specific ligand estrogen testosterone to bind to a receptor inside the cell. Without that molecular handshake, the genes for growth just don't get transcribed.
The work order never gets issued.
And the cell either goes dormant or, in the best case, it undergoes apoptosis. It dies.
So our mission for this deep dive is to map out how we intercept that message. And looking at the roadmap you've laid out, we've got a few key strategies.
3 main battlegrounds, really.
Right. First, there's receptor blockade, which you described as jamming the lock.
Yep, jamming the receiver.
Then there's synthesis inhibition, or shutting down the factory that makes the hormone.
Source control.
And finally, axis suppression, where we go all the way up to the brain to, cut the phone line?
Exactly. We cut the call from headquarters.
But we also have to talk about the cost of doing this. Because these hormones, they're not just tumor food, are they?
Not at all. They run everything. Metabolism, bone density, cardiovascular health. When you starve the signal for the tumor, the whole body feels that famine.
It's a system-wide intervention.
It has to be.
Okay, before we jump into the first mechanism, let's just orient everyone on the sources again. We're really leaning on Katzung for the clinical scaffolding.
The what do I prescribe first? Logic.
Right, and then Goodman and Gilman for the really deep, heavy molecular mechanics.
It's the perfect pairing, I think. Katzung gives you that clear, organized hierarchy of care, while Goodman and Gilman takes you right down into the nucleus and explains why the lock gets jammed.
And as always, we have to say this is an interpretive synthesis. We are building a conceptual map for you, a way to navigate this incredibly dense territory.
But you still have to walk the path yourself.
You absolutely have to. Open the chapters, look at the diagrams, especially the steroid synthesis pathways we'll be talking about. This deep dive is meant to prepare you for the reading.
It does not replace it.
It does not replace it. So, with that said, let's start with the why. Why on earth does a highly mutated, aggressive tumor still bother to listen to a hormone?
It's a fantastic question, and Goodman and Gilman gets very specific about what hormone-dependent actually means at the molecular level. We're not talking about a receptor on the cell surface, are we?
No, this isn't like, say, an opioid receptor sitting on the membrane just waiting for something to drift by in the blood.
Not at all. That physical distinction changes everything. Steroid hormones, so estrogen, testosterone, cortisol, they're lipophilic.
Fat-loving.
Right, so they don't knock on the door, they just slide right through the cell membrane like a ghost through a wall. They don't need a channel or a transporter.
So the action, the real security checkpoint, is on the inside.
Deep inside, the hormone floats through the cytoplasm and into the nucleus to find its target, the nuclear receptor.
Let's use the estrogen receptor, the ER, as our main example.
Perfect. So when estrogen finds an ER, the receptor undergoes this massive conformational change.
Okay, let's pause there. Conformational change is a term we hear all the time in pharmacology. What does it actually look like? What does it mean in this context?
Imagine the receptor is a complex, folded-up piece of origami held in a specific shape by these little protein bodyguards called chaperone proteins.
Okay, so it's inactive, it's quiet.
It's quiet. When the estrogen molecule docks into its binding pocket, it's like a key turning. The entire origami structure refolds into a new, active shape.
And that new shape shakes off the bodyguards.
It sheds the chaperones, and then it finds another receptor that's done the same thing, and they pair up. They dimerize.
So you have two receptors holding hands.
And that pair now has a new job. It moves to the DNA, and using these little structures called zinc fingers, it physically clamps onto specific sequences of DNA.
The hormone response elements.
Exactly. And once it's clamped on, it acts as a transcription factor. It is quite literally the finger that presses the print button for the genes that tell the cell to grow and divide.
That's a powerful image. The hormone isn't just a simple messenger. It is the key that unlocks the entire machine that copies the blueprint for cell division.
That's it, precisely. So when a pathologist says a breast tumor is ER positive, what they're saying is that the tumor cells are just filled with these empty receptors.
These empty chairs just waiting for estrogen to sit down and start shouting orders.
That's exactly it.
And Katsung gives a really critical clinical statistic here. This isn't just academic.
No, it's the first and most important question. Ketson notes that if a breast tumor is ER positive, there's a greater than 60% chance it will respond to hormonal therapy.
But if it's ER negative?
If those shares aren't in the room, you can drain every last drop of estrogen from the body and the tumor will not care. It's completely deaf to the signal.
It's already gone rogue.
It has, which is why that pathology report is everything. You have to know if the enemy is even listening before you try to jam their radio.
Okay, so let's move into that first major battlefield. Breast cancer and the strategy of the estrogen blockade. We know the mechanism now. Estrogen finds receptor, receptor hits DNA, tumor grows. So strategy one is to jam that lock.
Which brings us to the SERM's selective estrogen receptor modulators.
And the prototype, the absolute gold standard here, is tamoxifen.
The drug that basically defined this entire field of medicine.
Tamoxifen is so fascinating because it's not a simple on-off switch, is it? The name itself, modulator, implies something more complex than just blocker. Can you explain the selective part? How can a single drug be an antagonist? A blocker in one tissue, but an agonist, a stimulator in another?
This is one of the most elegant and also problematic mechanisms in pharmacology. It all comes back to that conformational change we just talked about.
The shape-shifting.
The shape-shifting. Tamoxifen is a competitive inhibitor. It physically fights with estrogen for that seat on the receptor.
Okay, so it gets into the chair first.
It sits in the chair. But because tamoxifen is shaped differently from natural estradiol, when the receptor protein folds around it, it ends up in a slightly different final shape. It's an off shape.
And in breast tissue, that off shape is a dud.
In breast tissue, that specific conformation fails to recruit the other proteins, the coactivators, that are needed to actually start DNA transcription. So it just sits there, jamming the lock. The gene stays off.
So in the breast, it's a perfect silencer.
It is.
Yeah.
But, and here's the selective part. The body is complex. The machinery available inside a bone cell is different from a breast cell. In bone tissue, that same tamoxifen-induced shape does manage to recruit the right coactivators. The bone cell's machinery looks at that shape and says, close enough, signal received, let's keep the bones strong.
That sounds like a miracle drug. You're blocking the cancer in the breast, but you're simultaneously protecting the patient from osteoporosis, which is a huge risk for postmenopausal women anyway.
It is a brilliant effect, but it has a dark side. The selectivity isn't perfect.
Of course not.
There's a third tissue to consider, the endometrium, the lining of the uterus.
And what does it do there?
In the endometrium, tamoxifen acts as a partial agonist. It gives a low-level but chronic stimulus for the uterine lining to grow.
Which is exactly why Katsung puts a huge red warning flag on this drug regarding the risk of endometrial cancer.
It's a 2 to 3-fold increased risk. Now, the absolute risk is still quite low, but it is real and it's significant. We are consciously trading a very high risk of breast cancer recurrence for a lower but manageable risk of uterine cancer.
So what does that mean clinically? You have to monitor these patients very closely.
Absolutely. Any abnormal uterine bleeding in a woman on tamoxifen is a major red flag that needs immediate investigation.
And I see another risk here too. Something about blood clots. Is that because the liver also sees it as an estrogen?
Yes, that's the mechanism. The liver produces many of our clotting factors, like fibrinogen, and it does so partly in response to estrogenic signals. Tamoxifen provides just enough of that signal in the liver to tick up the production of these factors.
Raising the risk of DVTs or pulmonary embolism.
Right. And Katzung makes a key point here, especially around surgery. You might even consider stopping the drug for a few weeks before a major elective procedure to bring that clot risk back down to baseline.
So tamoxifen is this brilliant but slightly dirty blocker that helps the bones but can harm the uterus. Do we have a cleaner version?
We do, raloxifene. It's a second-generation SERM.
And what's different about it?
It manages to keep the good parts. It's still an agonist in bone, protecting from osteoporosis, and an antagonist in the breast. But it does not stimulate the endometrium. It's an antagonist there too, so it doesn't carry that risk of uterine cancer.
Well, then why isn't it the standard? Why do we still use tamoxifen if raloxifene is safer?
Because in pharmacology, safer often comes with a trade-off, usually in potency or efficacy. In the high-stakes world of treating active breast cancer, tamoxifen just has a longer, more robust track record for preventing recurrence.
I see.
Raloxifene is mostly used for prevention in very high-risk women or for treating osteoporosis, where you also want the breast cancer prevention benefit. It's more of a prophylactic player.
Okay, so that's strategy A, jamming the lock. But sometimes jamming isn't enough. The tumor's too clever. Goodman and Gilman describes another approach, a drug that doesn't just jam the receptor. It destroys it.
Ah, yes. The SRDs, selective estrogen receptor downregulators, and the main one is fulvestrant.
What a name.
I like the nickname for this one, the shredder.
The shredder. Okay, how does that work? How is it different from tamoxifen?
Fulvestrant is what we call a pure anti-estrogen. No agonist activity anywhere. And according to Goodman and Gilman, it binds to the estrogen receptor with an affinity that's about 100 times stronger than tamoxifen.
So it grabs on and doesn't let go.
It grabs on, but it doesn't just sit there. It twists the receptor into such a mangled, unrecognizable shape that the cell's own internal quality control machinery sounds an alarm.
The cell realizes its own furniture is broken.
That's a great way to put it. The cell's ubiquitin proteasome system tags that broken receptor.
Puts a little trash me sticker on it.
That's exactly what ubiquitin is. It's the biological kick-me sign, and it sends the receptor to the proteasome to be chopped up and recycled.
It gets sent to the cellular wood chipper.
Yes. So the net effect is a profound downregulation of the receptor. The cell literally runs out of ears to hear the estrogen signal.
And when would you use this heavy hitter?
Typically, this is a second-line therapy. We use it when a tumor has become resistant to tamoxifen or in more advanced metastatic settings, often in combination with other drugs like CDK4/6 inhibitors.
This makes sense. I want to pivot now to the other main strategy in breast cancer. If blocking the receptor is plan A, then plan B has to be shutting down the factory.
The aromatase inhibitors.
And anastrozole, letrozole, exemestane, these are huge drugs.
Absolutely. And they target the enzyme aromatase. To understand why these work so well, you have to think about where estrogen actually comes from in the body.
It's not just made from scratch, it's converted from something else, right?
Right. All steroid hormones are related. Estrogens actually start their life as androgens male hormones like testosterone or androstenedione. The aromatase enzyme is what performs the final critical chemical step to turn them into estrogens.
It aromatizes one of the rings in the steroid structure.
Exactly. So these drugs block that final conversion step. No aromatase, no estrogen.
But Katzung is extremely specific about the patient population here. It says these are for postmenopausal women. What would happen if I gave an aromatase inhibitor to a, say, 30-year-old woman with breast cancer?
You would trigger a physiological crisis. In a premenopausal woman, the ovaries are the main estrogen factory, and they are under the direct command of the brain. The pituitary is pumping out FSH and LH, telling them to work. If you block estrogen production with an AI, her estrogen levels will drop for a day or two.
And the brain will notice that drop.
The brain will panic. It has a thermostat, a negative feedback loop. The hypothalamus and pituitary will sense the low estrogen, and they will scream louder. They will pump out massive, overwhelming amounts of FSH and LH to try to force the ovaries to overcome the block.
It's like flooring the accelerator while someone is standing on the brake hose.
Perfect analogy. The ovaries are just too powerful a factory to be suppressed by AIs alone in that context. You end up with ovarian hyperstimulation.
But in a postmenopausal woman,
the ovaries have retired. They're quiet. Her main source of estrogen is no longer the gonads. It's from peripheral tissues, especially body fat.
So fat cells have aromatase.
Yes. They take weak androgens made by the adrenal glands, which are still working, and they convert them locally into estrogen. It's a much smaller, quieter, more diffuse factory.
And one that the aromatase inhibitors can shut down effectively.
Completely, and without that massive feedback loop from the brain trying to override it.
So in this postmenopausal population, are these drugs actually better than tamoxifen?
The clinical data suggests that, yes, they are often superior in preventing recurrence. Standard practice now is often to use an AI, or to start with tamoxifen for a couple of years and then switch to an AI.
But there's always a trade-off. We said tamoxifen protected the bones.
And aromatase inhibitors do the exact opposite.
They starve the bones of every last bit of estrogen.
Which leads to a significant increase in the risk of osteoporosis and fractures. One of the most common complaints from patients on these drugs is joint pain, or arthralgia. It's a real quality of life issue.
It just feels like the recurring theme of pharmacology. You squeeze the balloon in one place.
And it always bulges somewhere else.
Let's move on. Conceptually, to the other side of the hormonal coin, prostate cancer?
Right.
The target here is androgen, testosterone.
The principles are very similar, but I would say the intensity is dialed way up. In breast cancer, we talk about modulation and blockade.
In prostate cancer, the clinical term is surprisingly blunt.
It is. It's medical castration.
The goal is to get testosterone levels down to essentially zero.
Down to the levels you would see in a man who has had his testicles surgically removed. We call it ADT, or androgen deprivation therapy.
And the most common way we do this, paradoxically, is with a class of drugs that seems completely counterintuitive. GnRH agonists. Leuprolide is the big one. An agonist is a stimulator. Why are we stimulating the very system we're trying to shut down?
This requires a really deep appreciation for the body's signaling rhythms, the whole hypothalamic pituitary gonadal axis.
Okay, walk us through it.
The hypothalamus releases GnRH gonadotropin-releasing hormone to tell the pituitary to release LH. LH then travels to the testicles and tells them to make testosterone. But the crucial detail, the one everything hinges on, is that the hypothalamus releases GnRH in a pulsatile fashion. It sends a little squirt, then it waits, then another squirt.
It's a rhythmic drumbeat, not a continuous drum.
Exactly. The receptors on the pituitary are designed to hear that rhythm. They need the silence between the beats to reset themselves.
And a drug like leuprolide
Provides a continuous, high-volume, unrelenting scream. It floods the receptors with stimulation with no break.
So the pituitary just gives up. It gets overwhelmed.
It desensitizes. It says, this is too much noise, and it literally pulls its receptors off the cell surface. It internalizes them. It downregulates. After about a week or two of this continuous scream, the pituitary goes deaf.
It stops making LH, and the testicles turn off.
The testosterone factory shuts down.
But you said after a week or two. What on earth happens during that first week?
The flare. That's the danger.
The flare.
Because the drug is technically a powerful agonist, the very first thing it does is cause a massive surge in LH and, consequently, testosterone. The pituitary shouts one last time before it goes deaf.
That sounds absolutely catastrophic if you have a man whose body is full of testosterone-fueled tumors.
It is a major, major liability. If a patient has metastases in his spine, that tumor flare can cause the tumor to swell and compress the spinal cord.
Leading to paralysis.
Or just excruciating bone pain. It can be a real disaster.
So you can't just give the shot and send the patient home. How do you manage this?
You have to build a bridge. For the first few weeks of therapy, you must co-administer an anti-androgen, a direct receptor blocker like bicalutamide.
A shield.
A shield. It sits on the androgen receptor and blocks it so that when that testosterone surge comes, it has nowhere to go. Once the flare is over and the pituitary is shut down, you can safely stop the anti-androgen.
It seems so complicated. Why don't we just use a GnRH antagonist? A drug that just blocks the receptor from day one with no stimulation.
We have them. A drug called daguerreotyx does exactly that.
A clean cut.
A clean cut, no flare, immediate drop in testosterone. It works beautifully.
So why is leuprolide, with its dangerous flare, still the standard of care in most places?
It often comes down to pharmacology and logistics. Daguerreotyx often requires monthly injections that can cause significant injection site reactions. Leuprolide, on the other hand, can be formulated into a depot injection.
A slow-release implant.
Right. A single shot that can last for 3, 4, even 6 months. In the world of chronic cancer care, minimizing hospital visits and improving patient convenience is a huge factor. The long-acting formulation of the agonist usually wins out.
That makes a lot of sense from a practical standpoint. Now, I want to move to the real heavy artillery, We've talked about cutting the signal from the brain, but Goodman and Gilman dedicates a lot of space to a drug called abiraterone, which works on a totally different, much deeper level.
Abiraterone is a masterpiece of biochemical engineering. It's an inhibitor of an enzyme called CYP17A1.
Okay, break that down for us. CYP17A1. This enzyme isn't just in the testicles, is it?
No, and that's the whole point. That's why this drug is so important. Prostate cancer is incredibly devious. When you perform medical castration with leuprolide, you shut down the testicles. The tumor, after a while, often says, fine, I'll get my androgens from the adrenal glands instead.
The adrenals make androgens.
They make weak androgens, yes. Or worse, the tumor learns to make its own.
The tumor itself becomes an androgen factory, an autocrine loop.
Precisely. It learns to synthesize its own fuel internally. But whether it's in the testes, the adrenals, or the tumor itself, it needs the enzyme CYP17A1 to do it.
It's a critical step in the assembly line.
It is the key fork in the road in the steroid synthesis pathway. Abiraterone irreversibly inhibits CYP17A1 everywhere. It is a total global shutdown of the androgen supply chain.
But I'm looking at the steroid pathway diagram right now in the textbook, and I really encourage our listeners to pull this up. CYP17A1 seems to be required for two things.
It is.
If you block it, yes, you stop the production of sex hormones, but you also stop the production of cortisol.
And you absolutely cannot live without cortisol.
So the body has to react to that, right? The feedback loop must go crazy.
It does. The brain senses the critically low cortisol levels and it panics. It screams at the adrenal glands via a hormone called ACTH. It's shouting, make more cortisol, we're in a crisis.
But the adrenal gland can't. The CYP17A1 door is locked by abiraterone.
So all the raw material, all that cholesterol precursor that's flooding into the adrenal gland can't go down the cortisol path. It gets shunted down the only other available pathway.
The mineralocorticoid pathway.
The aldosterone pathway. And the patient ends up functionally overdosing on mineralocorticoids. They retain huge amounts of salt and water, their blood pressure skyrockets, their potassium levels plummet. It can be lethal.
This sounds like an unusable drug. How do we possibly give this to someone safely?
We have to perform a physiological hack. A beautiful, elegant trick. We co-administer a low dose of prednisone, which is a corticosteroid.
To replace the missing cortisol.
That's part of it, yes. But the main reason is to fool the brain. The prednisone signal goes up to the hypothalamus and says, hey, calm down, we've got plenty of corticosteroid on board.
And the brain stops screaming ACTH.
The ACTH production plummets. The adrenal glands stop being overstimulated, and the flood of precursors into the mineralocorticoid pathway stops. You fix the side effect by tricking the master feedback loop.
That is just incredible. One drug to break the cancer and a second drug to patch the physiological hole you just blasted in the system.
It's systems pharmacology at its finest. And there's one more critical pearl on abiraterone from Goodman and Gilman, the food effect.
Oh, right, I saw this. Usually you tell patients to take powerful medications with food to avoid stomach upset.
You do the opposite here. You must tell them, do not take this with food.
Why?
Food, particularly fatty food, increases the absorption of abiraterone from the gut by up to tenfold.
Tenfold? That's not a minor variation, that's a massive overdose.
It's an overdose. Taking this pill with a cheeseburger could create dangerously toxic levels in the blood. So it absolutely must be taken on an empty stomach to keep the dose consistent and safe.
That is such a critical counseling point. Let's touch on the outlier in our stack of research for today. Glucocorticoids. We just talked about prednisone as a fixer drug for abiraterone.
Right, as a support agent.
But in certain cancers, like leukemia, prednisone isn't the support, it's the killer.
It's a fascinating and strange duality. In almost every other tissue in the body, glucocorticoids are anti-inflammatory and immunosuppressive. They generally keep cells alive and quiet things down.
But not in lymphocytes.
In lymphocytes, so B cells and T cells, the glucocorticoid receptor is wired differently. When a steroid like prednisone or dexamethasone activates it, it doesn't trigger a growth or survival signal. It triggers a death spiral.
Apoptosis. Programmed cell suicide.
It induces what's called lympholysis. The cell literally dissolves. And this is why high-dose prednisone is a cornerstone of chemotherapy regimens for childhood. Acute lymphoblastic leukemia, or ALL.
It's part of the famous VAMP regimen.
That's right. Vincristine, amethopterin, which is methotrexate mercaptopurine, and prednisone. In that cocktail, the steroid isn't there to manage side effects. It is an active cytotoxic agent against the cancer itself.
Which brings us to the inevitable countermove from the cancer. Resistance.
Yes.
We've been talking about all these clever ways to starve the signal, but the old saying from Jurassic Park, life finds a way, Seems to apply to tumors, too. How do they learn to survive the starvation?
They have a whole playbook of escape mechanisms. The simplest one is they just stop listening.
What do you mean?
The tumor just stops making the receptor. An ER-positive breast cancer can, under the selective pressure of our drugs, evolve into an ER-negative tumor.
And at that point, all of our hormonal therapies become useless. They have no target.
Exactly. The radio is gone. Another common method is what Goodman and Gilman calls crosstalk. The tumor activates a completely different growth pathway to get around the block. For instance, it might massively upregulate the HER2/neu pathway. It essentially says, okay, you've locked the estrogen front door. Fine, I'll just open the growth factor window and climb in that way.
It bypasses the need for the hormone entirely.
It finds an alternate route. But perhaps the most insidious mechanism is what we see in prostate cancer. The broken lock mechanism.
You're talking about the splice variants. ARV7 is the famous one.
That's the one.
Can you explain what a splice variant is? How does that work?
So think of the normal androgen receptor protein as having two critical parts. There's a cup at one end where the testosterone molecule sits. That's the ligand-binding domain.
Okay.
And there's a hand at the other end that actually grabs onto the DNA binding domain.
Right.
The ARV7 splice variant is a version of the receptor that, due to a genetic mutation, is built without the cup. The entire ligand-binding domain is just gone.
So there's no place for testosterone or our drugs to bind.
Exactly. But, and this is the absolute kicker, the hand part, the DNA binding domain is stuck in the on position. It is permanently clamped onto the DNA, driving growth 247 without needing any testosterone at all. It's constitutively active.
And our most advanced anti-androgens, like enzalutamide, they all work by targeting the cup.
They all target the ligand-binding domain, which in ARV7 no longer exists. Our drugs are trying to block a pocket that has been completely deleted from the protein.
That's a checkmate move by the tumor.
It is the frontier of resistance research right now. How do we develop drugs that can target that hand directly instead of the cup?
Before we wrap up with our final thoughts, we have to talk about the patient, the clinical balance section. We're systematically removing some of the most fundamental hormones in the human body. This isn't just about cells in a dish. It's about people's lives.
This is where the systems thinking we talked about becomes so critically important. You cannot pull a thread this major estrogen or testosterone without the entire tapestry of physiology changing.
Let's start with the metabolic cost. What happens to the body's engine?
Both of these hormones play huge roles in regulating lipids, glucose, and body composition. Men on ADT, for example, tend to gain fat, lose muscle mass, and develop insulin resistance. Their risk for developing diabetes and cardiovascular disease climbs significantly.
So you could cure their prostate cancer.
Only for them to have a fatal heart attack 5 years later because of the therapy. It's a very real concern.
And the bone health issue seems to be universal for both men and women on these therapies.
It is. Estrogen and testosterone are the primary guardians of bone density. When we use aromatase inhibitors in women or ADT in men, we are essentially inducing rapid onset, severe osteoporosis.
So we have to be proactive.
Very. We monitor with DEXA scans, we supplement with calcium and vitamin D, and often we have to treat them aggressively with drugs like bisphosphonates to prevent devastating fractures.
And then there's the part that's harder to measure, the quality of life. The terms we use are induced menopause and chemical castration. But what is that like to live through?
It is profound. The fatigue can be crushing. The hot flashes, the cognitive changes or brain fog, the complete loss of libido. It fundamentally changes how a person feels in their own body.
Adherence to the therapy must be a huge challenge.
It's a massive struggle. It's easy for us to sit here and discuss the elegance of a molecular mechanism, but for the patient taking that pill every day that makes them feel old and weak and not themselves, that is a heavy, heavy burden. The clinician's job is just as much about managing these symptoms and validating the patient's experience as it is about tracking their cancer markers.
So let's try to pull this all together. What is the grand synthesis from this deep dive?
I think it's that we've really moved from an era of purely poisoning the cell to one of starving the signal.
Yeah.
We've developed these incredibly intelligent tools, SERMs, AIs, GnRH agonists, anti-androgens, that can manage these cancers in many cases for years or even decades.
We're turning what was once a rapidly terminal disease into a chronic, manageable condition.
We are, but it's a constant chess match against a very smart, adaptive enemy. The tumor will mutate. It will change the locks. It will bypass the roads. It will build its own factories.
And our treatments, as powerful as they are, come with a steep systemic cost. We are tinkering with the master dials of human physiology, and there are always consequences.
Always.
So here's a final thought for our listeners to chew on as we wrap up. We've spent this entire hour focusing on the receptor, on the ignition switch of the car.
Right, the ligand-binding event.
But the car is ultimately driven by the engine, the gene transcription machinery itself, downstream of the receptor. As we see these resistance mechanisms, like the ARV7 splice variant that literally deletes the ignition switch but leaves the engine running hot, does the future of this field lie in bypassing the receptor entirely?
That's the question.
Could we develop drugs that don't care about the hormone or the receptor, but they can go in and specifically jam the transcription process at the level of the DNA itself?
That is the holy grail. Targeting the transcriptional machinery directly. There are drugs in early trials, things like bromodomain inhibitors, that are trying to do just that. If we can find a way to silence the engine instead of just blocking the ignition, we might finally be able to outsmart resistance for good.
That's the frontier. For those of you who really want to see the maps of the territory we've been exploring, please open Cadsong Chapter 54 and Goodman and Gilman Chapters 68.
And I can't stress this enough. Find those steroidogenesis pathway diagrams. If you can actually trace the path from cholesterol all the way down to testosterone and then to estrogen, and put a big red X where abiraterone and anastrozole strike, you'll understand this on a whole new level.
Don't just read it, draw it out. The podcast builds the framework.
But the reading fills the foundation.
Thank you for diving deep with us.
Until next time.